A very good morning to all of you. Today, our topic of discussion is going to be neonatal cholestasis. This is a very important cause of congenital hyperbilirubinemia in our children, and it needs quick evaluation and prompt treatment. So, let us study about neonatal cholestasis. So firstly, the objectives of the study, it's mainly to know the differential diagnosis for neonatal cholestasis. It is to understand how to evaluate the neonate with conjugated hyperbilirubinemia and to know the therapeutic management of neonates with cholestasis. Coming to the definition proper of neonatal cholestasis, it is defined as conjugated hyperbilirubinemia developing within the first 90 days of extrauterine life. Or as per Nelson, it has been given that neonatal cholestasis is biochemically defined as conjugated hyperbilirubinemia or jaundice persisting for more than 14 days of life. So here the conjugated bilirubin exceeds 1.5 to 2 milligrams per deciliter, and moreover it is defined as conjugated hyperbilirubinemia when the conjugated bilirubin generally exceeds 20% of the total bilirubin. So coming to the etiologies, neonatal cholestasis is widely caused by extrahepatic and intrahepatic etiologies. So neonatal cholestasis, when it is caused by intrahepatic etiology, so there is an intrahepatic disease, which could be either there is an injury to the liver or the hepatocyte per se, or there is a bile duct injury. So when the hepatocyte injuries are caused by metabolic disease, viral disease, or there could be idiopathic neonatal hepatitis, which is a type of familial hepatitis, whereas it could also be because of bile duct injury, because of an intrahepatic bile duct or its paucity. And extrahepatic disease is our main concern because that is the more common type of conjugated hyperbilirubinemia that occurs. So extrahepatic disease is because of bile duct injury or obstruction, that is mainly known as extrahepatic biliary atresia. So first focusing on the extrahepatic etiologies, because this needs very prompt and very quick decision making for treatment. So first of all, extrahepatic biliary atresia is the most common cause of extrahepatic etiologies of neonatal cholestasis. Other things could be a choledochal cyst, bile duct stenosis, so bile duct stenosis, spontaneous perforation of the bile duct, polylithiasis, inspissated bile or mucus plug, extrinsic compression of the bile duct. So we have to keep in mind that in these cases, the liver function is normal, almost normal. The liver is able to produce the bilirubin, but the clearance of the bilirubin, conjugated bilirubin, is not occurring. So extrahepatic pathologies. So it is basically a difficulty in the biliary tree. Then coming to intrahepatic etiologies, which could be because of both hepatocyte injury and intrahepatic bile duct injuries. So the causes are idiopathic, toxic, genetic or chromosomal, infectious, metabolic, and miscellaneous. And the various causes I have enumerated in the next slides. So firstly, idiopathic neonatal hepatitis. Idiopathic neonatal hepatitis is a familial type of hepatitis where many other syndromes are also there, and progressive familial intrahepatic cholestasis is also there. Then toxic. Toxic cholestasis occurs because of PPN-associated or drug-induced cholestasis. Genetic or chromosomal is seen in case of trisomy 18 and trisomy 21, like Down syndrome. Infections. Various infections cause conjugated hyperbilirubinemia or stop the clearance of bile. So that is basically in case, most commonly in cases of bacterial sepsis, moreover gram-negative sepsis like E. coli, or torches, hepatitis like hepatitis B and C. And in viral infections, it could be like, hepatitis, varicella, Coxsackie virus, ecovirus, and tuberculosis also. Now, metabolic disorders. There are multiple metabolic disorders, and these can be divided into disorders of carbohydrate metabolism, amino acid metabolism, and lipid metabolism. So disorders of carbohydrate would be galactosemia, fructosemia, and glycogen storage disorders type 4. Disorders of amino acid like in tyrosinemia and hypermethionemia. Lipid metabolism like in Niemann-Pick disease, Wolman disease, Gaucher disease, and cholesterol ester storage disease. And disorders of bile acid metabolism can also be there. Certain paroxysmal disorders like Zellweger syndrome and adrenoleukodystrophy, and endocrine disorders like hypothyroidism, as we have studied, leads to intrahepatic cholestasis. Certain miscellaneous metabolic disorders like alpha-1 antitrypsin deficiency, cystic fibrosis, neonatal iron storage disease, and North American Indian cholestasis also causes intrahepatic cholestasis. Other causes are arteriohepatic dysplasia like allergen syndrome, non-syndromic paucity of intrahepatic bile ducts, Carrelli's disease, Byler's disease, and congenital hepatic fibrosis. Familial benign recurrent intrahepatic cholestasis, hereditary cholestasis with lymphedema, histiocytosis X, shock, and neonatal lupus can also cause intrahepatic cholestasis. Now, what are the commonest etiologies amongst so many types of etiologies which cause cholestasis? So in case of premature infants, it is mainly because of sepsis and drugs, and also because of the use of PPM, in which the intralipid portion is responsible for cholestasis. Then idiopathic neonatal hepatitis is also a common cause of intrahepatic cholestasis. Extrahepatic biliary atresia, alpha-1 antitrypsin deficiency, and other intrahepatic cholestasis syndromes, as we have read. Now, coming to the clinical presentation, first and foremost, there is going to be this lemon yellow type of discoloration of the entire body, including palms, soles, everything, and mucous surfaces, that is jaundice. Then scleral icterus. With that, we are going to find hepatomegaly. If it is a hepatocyte-associated injury, then hepatomegaly is quite evident. Then acholic stools. Now, acholic stools is moreover a criteria in case of extrahepatic biliary atresia, whereas in case of idiopathic neonatal hepatitis, pigmented stools are present. Dark urine and other signs and symptoms depend on specific disease process. So, what are the goals of timely evaluation? So, we diagnose and treat known medical and/or life-threatening conditions. We identify disorders amenable to surgical therapy with an appropriate time frame, and also avoid surgical intervention in case of intrahepatic cases, because a surgical correction is mainly needed in case of extrahepatic biliary atresia, not in the intrahepatic etiologies. Now, coming to basic evaluation. In evaluation, first step is going to be history and physical examination. From what age after birth the child has been passing what color stools, have there ever been pigmented stools at all, or they have always been acholic stools, has there been, from when have they noticed jaundice, did the jaundice ever subside, has there been any familial incidents, any previous sibling who had the same complaints, etc. Then CBC and reticulocyte count. Also, other routine investigations like renal function and the liver function tests comprising of SGOT, SGPT, GGT, alkaline phosphatase, total and direct bilirubin, and protein to evaluate the functioning of the liver. Whether all the liver functions are intact or not, we will do all the tests, and the coagulation profile is important because even in case of PHBA, coagulation profile can be mildly diminished. So we have to rule out the infectious causes of hepatitis, therefore test for infectious causes, which are indicated by cultures of blood, urine, and CSF, torch titers, VDRL, urine for cytomegalovirus, hepatitis B and C serology, and also ophthalmological examination, for example, for Wilson's disease. Next is the metabolic workup, because we have gone through so many metabolic and miscellaneous metabolic causes which are responsible for neonatal cholestasis. So we have to do a protein electrophoresis, alpha-1 antitrypsin level, thyroid function tests, sweat chloride for cystic fibrosis, urine and serum amino acids, and other newborn metabolic streams, then urine reproducing substances and bile acids. So there are certain very specific tests in the evaluation of children with neonatal cholestasis, and what are the rationale behind the tests have also been mentioned. So firstly, we have to do the serum bilirubin fractionation in order to ascertain that it is conjugated bilirubin, which indicates cholestasis. Then assessment of the stool color. Does the baby have pigmented or apolic stools, which indicates the bile flow into the intestine? Suppose there is an extrahepatic biliary atresia. So the bile ducts have been completely injured, and through the atretic bile ducts, we are not going to have any pigmented stools. Whereas in case of idiopathic neonatal hepatitis, pigmented stools are present. So this is a very important distinction. Therefore, it indicates the bile flow into the intestine. Then, why do we do urine and serum bile acids measurement? This mainly takes part to confirm cholestasis and may indicate an inborn error of the amino acids, etc. will indicate moreover towards inborn error of bile acid biosynthesis. Then hepatic synthetic function in the form of albumin and the coagulation profile indicates the severity of hepatic dysfunction. Alpha-1 antitrypsin phenotype, it suggests or excludes the PIZZ type. Thyroxine and TSH to know if it is because of panhypopituitarism or hypothyroidism. Sweat chloride and mutation for cystic fibrosis. Urine and serum amino acids have to be checked in order to suggest any metabolic liver disease. Whereas ultrasound has to be done in order to see whether it is a neonatal hepatitis or a hepatocyte associated injury, or it is the biliary system. So it suggests choledochal cyst. It can distinguish between choledocholithiasis, any choledochal cyst, where in the biliary tree exactly the deformity is present, and whether it is hepatitis or whether it is solely a biliary tract associated disease. And finally, HIDA-scan or hepatobiliary scintigraphy, which documents bile duct patency or obstruction, and has got different results in case of INH, that is idiopathic neonatal hepatitis, and EHBA, that is extrahepatic biliary atresia. And finally, liver biopsy, which distinguishes again biliary atresia and hence suggests an alternative diagnosis. Now coming to the radiological part of evaluation. So ultrasonography, patient should be NPO in order to increase the likelihood of visualizing the gallbladder, and feeding with the exam may demonstrate a rather functioning gallbladder. Then hepatobiliary scintigraphy, but for this, 5 days prior to the HIDA scan, we have to feed the child with phenobarbital in order to maximize in order to clear the cholestasis, because this is phenobarbital, as we know, is a cholerectic drug. Now, next comes the invasive studies. So in that we have duodenal intubation, percutaneous liver biopsy, percutaneous transhepatic cholangiography, ERCP or endoscopic retrograde cholangiography, cholangiopancreatography, exploratory laparotomy with intraoperative cholangiogram. The last point, that is exploratory laparotomy with intraoperative cholangiogram, is rather our therapeutic step as compared to just diagnosis. Now coming to extrahepatic biliary atresia, this is the most important topic under neonatal cholestasis, both because this is the commonest cause of neonatal cholestasis for us, almost 85%. So let us dig deep into it. All right. So EHBA is the obliteration of the entire extrahepatic biliary tree at or above the porta hepatis. It is the most common form of EHBA, that is 85% of the children have got this. That is the neonatal for EHBA. Now, basically, EHBA is of 3 types. It is fetal, then there is neonatal, and presents a much more difficult problem in surgical management. Most patients with biliary atresia, that is 85 to 90%, are normal at birth and have a postnatal progressive obliteration of bile ducts. Embryonic or fetal onset form manifests at birth. It is mostly associated with other congenital anomalies like situs inversus, polysplenia, intestinal malrotation, and complex congenital heart diseases. Or it could also be associated just with the polysplenia spectrum, which is the biliary atresia splenic malformation. And postnatal onset may be an immune or infection mediated process. So this is the mechanism of perinatal and embryonic biliary atresia. So in perinatal biliary atresia, first of all, there is a perinatal infection like a torch infection or so, which perinatally itself causes bile duct epithelial cell injury, and there is expression of antigen, which leads to further inflammation and autoimmune response. That could also be augmented by a genetic predisposition. Then, because of this severe inflammatory immune response, the biliary duct and the biliary tree is going to undergo apoptosis, fibrosis, and finally the obstruction of the biliary ducts. That leads to an intrahepatic cholestasis and inflammation. Whereas in case of embryonic biliary atresia, there is already an abnormal biliary bile duct development because of a gene mutation. That abnormal development leads to bile duct obstruction. Hence, when there is bile flow, leads to bile flow initiation, hepatocellular injury, which further leads to an inflammatory autoimmune response, and therefore all of this leads to intrahepatic cholestasis and inflammation. And this further leads to fibrosis and biliary cirrhosis. So coming back to extrahepatic biliary atresia, the clinical features, there are generally persistent acholic stools with no pigment at all, and with onset at about 2 weeks old. The children are of average birth weight. There might be hepatomegaly, which is firm to hard consistency on examination per abdomen. It is more predominant in the female children. And there is no well-documented familial cases. The extrahepatic biliary atresia does not have much familial predisposition. Next, coming to the diagnostic workup. So the first important thing is imaging by ultrasound. And ultrasound ultrasound is very important because it helps us to note choledocholithiasis, any choledochal cysts, where exactly at which point there is an injury to the bile ducts. So the actual point of deformity also helps us to note whether it is only the biliary tree or the entire hepatobiliary system. So what is going on with the liver, how much is there any onset of cirrhosis or any hepatocyte injury or so. And it also at the same time helps us to know about the other syndromes and other deformities that might be present along with embryonic onset extrahepatic biliary atresia. So ultrasound has an increased incidence of picking up of polysplenia syndrome and intra-abdominal other vascular anomalies. What we are trying to see more importantly is gallbladder, because gallbladder is either not at all visualized or is a totally micro gallbladder. And a pathognomonic sign of on the ultrasound is a triangular quartz sign, which represents a cone-shaped fibrotic mass cranial to the bifurcation of the portal vein, which may be seen in patients with biliary atresia, not seen in INH. The echogenic density, which represents the fibrous remnants at the porta hepatis of biliary atresia cases at surgery, may be a helpful diagnostic tool in evaluating the patients with neonatal cholestasis. Then we come, it is basically, so ultrasound helps us to find the fibrous remnants or any remnants at all of biliary atresia. And that is a very important diagnostic tool. Then hepatobiliary scintigraphy. For this, 5 days prior to the scan, we have to give the child phenobarbital, and then on HIDA scan, we see a normal uptake of the radionucleotide scan with absent excretion. Because there is atresia and blockage, there is no excretion of the dye of the radionucleotide, but there is a normal uptake. And percutaneous liver biopsy, This shows bile duct proliferation, bile plugs, portal or perilobular fibrosis and edema, and an intact lobular structure. The hepatocyte and the hepatic lobules are intact. Now coming to the management, the first step is going to be exploratory laparotomy and direct cholangiography. So as I had said, this is a therapeutic step in the management of extrahepatic biliary atresia, because we have to find out, first of all, at what point there is obstruction. Is it idiopathic neonatal hepatitis, or it involves the biliary tree? What all parts and till what extent the hepatobiliary system is involved, and more importantly, whether it is a correctable or a non-correctable type of deformity. So direct drainage can be accomplished in the few patients with a correctable lesion with the help of this procedure. Next, coming to Kasai procedure, in the few cases that are correctable, we have to do the Kasai procedure, that is hepatoportoenterostomy. This is done in cases where no correctable lesion is found. So the rationale behind Kasai procedure is that minute bile duct remnants, which represent residual channels, may be present in the fibrous tissue of the porta hepatis. Such channels may be in direct continuity with the intrahepatic ductile system. And in such cases, if there is a transection of the porta hepatis with anastomosis of the bowel to the proximal surface of the transection, it might finally allow bile drainage. So important points are that if the flow is not rapidly established in the first month of life, progressive obliteration and cirrhosis ensue. If microscopic channels of patency more than 150 microns in diameter are found, the postoperative establishment of flow is likely. And the success rate for establishing a good bile flow after the Kasai operation is much higher. It's performed before 8 weeks of life. If performed before 8 weeks of life. So within the first month, if the flow is not ensured, obliteration, cirrhosis, and therefore further damage will occur. If microscopic channels are more than 150 microns, establishment of bile flow is likely. And if Kasai procedure is operated before 8 weeks of life, there is 90% chance of success. So Kasai procedure, the success of the operation is dependent on the presence and size of ductal remnants, the extent of the intrahepatic disease, and the experience of the surgeon. Complications are ascending cholangitis and reobstruction, as well as failure to re-establish bile flow. And advantages are decompression and drainage sufficient to now basically when there is non-correctable causes and there is constant cholestasis, as a result of which there is a continuous process of ongoing dynamic inflammation in the entire hepatobiliary system, and that is going to lead to a lot more further cirrhosis and finally hepatocellular failure as well, as a result of which this Kasai procedure leads to decompression and drainage that is sufficient to forestall the onset of cirrhosis and sustain growth until a successful liver transplantation can be done. Now coming to idiopathic neonatal hepatitis, which is the second most important cause of neonatal cholestasis. So here, generally normal stools or ecolic stools with onset at 1 month old. Idiopathic neonatal hepatitis is moreover seen in case of prematurity or small for gestational age babies. Normal liver on exam or hepatomegaly with normal to firm consistency. This is rather more common in males as compared to EHPA, which is more common in females. And familial preponderance of 15 to 20% is noted in INH, which is not there in case of EHPA. Now, when we do a radionucleotide HIDA scan here, that is hepatobiliary scintigraphy, there is an impaired uptake in INH, whereas there was normal uptake in case of EHBA. There is normal excretion in case of INH, and impaired excretion in case of EHPA. Here, the biopsy first of all shows intralobular inflammation where there was normal lobules in case of EHBA with focal hepatocellular necrosis and disruption of the hepatic architecture. There is no alteration of the bile ducts. Giant cell transformation occurs, but it is non-specific. So this is more in terms of biopsy showing cirrhosis and necrosis-like findings, and biliary bile duct structure is intact here. Next cause is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin makes up 90% of alpha-1 globulin fraction, and it is associated with PIZZ. About 10 to 20% will have liver disease, and rarely these are genes with PISZ and PIZ null phenotypes. Biopsy here shows hepatocellular edema, giant cell transformation, necrosis, and pseudoacinar formation. Biopsy also shows the accumulation of Pas-positive diastase-resistant globules in the cytoplasm of periportal hepatocytes. There are varying degrees of fibrosis which correlate with disease prognosis. And there are certain intrahepatic cholestatic syndromes which we should know. These include several diagnostic entities. Most important is progressive familial intrahepatic cholestasis, PFIC, which is further again of 3 types. And biopsies, then there is Alagille syndrome, Zellweger syndrome, adrenoleukodystrophies, Argine syndrome. So biopsies show cholestasis, which may show paucity of the intrahepatic bile ducts, giant cell transformation, and/or fibrosis. So coming to the treatment, in surgical treatment, it is mainly Kasai procedure for biliary atresia, limited bile duct resection and reanastomosis, or if there is choledochal cyst, then excision, cholecystectomy in case of cholelithiasis, and liver transplantation is the mainstay and gold standard treatment. Liver transplantation, the survival rates approach 80% at 1 year and 70% at 5 years. Biliary atresia is the most common indication for transplant and may be the initial treatment when detected late, or may be used as a salvage procedure for a failed Kasai. It is used early in cases of tyrosinemia. Coming to treatment, medical management. So in medical management, it is divided into nutritional support, treatment of pruritus secondary to jaundice, cholerectics and bile acid binders, and management of portal hypertension and its consequences. So in nutritional support, we have to give adequate calories and protein. Supplement calories with medium chain triglycerides, because as the liver is involved, it will not be able to break down the long chain fatty acids completely. So therefore, we try to supplement more amount of MCTs or medium chain triglycerides. Treatment or prophylaxis for all the fat soluble vitamins, that is vitamin A, D, E, and K, have to be supplemented. So this is as per Nelson, the suggested medical management of persistent cholestasis, malnutrition resulting from the malabsorption of dietary long-chain triglycerides, therefore replaced with dietary formula or supplements containing medium-chain triglycerides. Then the fat-soluble vitamin malabsorption, so vitamin A deficiency can cause night blindness and xeroderma or thick skin. So we have to replace that with 10,000 to 15,000 international units per day as Aquasol A. Vitamin E, for which the deficiency can cause neuromuscular degeneration, that's tocopherol. So replace with 50 to 400 international units per day of oral tocopherol or TPGS. And vitamin D deficiency will cause metabolic bone disease or rickets, osteopenia, and therefore we have to replace that with 5,000 to 8,000 international units per day of D2, or 3 to 5 mcg per kg per day of 25 hydroxycholecalciferol. And vitamin K deficiency can cause hypoprothrombinemia, so replace with 2.5 to 5 mg every other day as water soluble derivative of lenadiol. So vitamin K deficiency can lead to our coagulation factors ka defect. Then micronutrient deficiency, mostly zinc and calcium and phosphate. Oral formulations are available to supplement all of these. Deficiency of water-soluble vitamins, supplement with twice the recommended daily allowance. We have bicosals, and retention of biliary constituents such as cholesterol, itch or xanthomas, administer cholerectic bile acids, that is ursodeoxycholic acid, 15 to 30 mg per kg per day. And if there is progressive liver disease or portal hypertension like variceal bleeding, ascites, or hypersplenism, interim management, control bleeding, salt restriction, and spironolactone. And in case of end-stage liver disease or liver failure, transplantation. So basically, neonatal cholestasis, the highest and the gold standard treatment is going to be liver transplantation, but it can be stalled by Kasai procedure. And for persistent cholestasis, the supportive treatment, we have to supplement adequate calories for malnutrition, take care by oral formulations for vitamins A, D, E, and K, that is the fat-soluble vitamins. Instead of long-chain fatty acids, supply oral formulations of medium-chain triglycerides. Then micronutrient deficiencies like zinc supplementation and calcium and phosphate supplementation has to be done. Retention of, we have to provide with cholerectics and monitor for progressive liver disease. So treatment of pruritus is done with bile acid binders like cholestyramine, cholestyramine, ursodeoxycholic acid, phenobarbital used as a cholerectic in this case, naloxone, and rifampin. For portal hypertension, we have dealt with this in detail in another class as well, but portal hypertension and its consequences can be variceal bleeding. So for that, we have to do sclerotherapy, endoscopic banding, balloon tamponade, shunts, propranolol, octreotide. Then for ascites, we have to do sodium restriction and diuretics like spironolactone, potassium sparing, or furosemide, albumin, and paracentesis. Thrombocytopenia managed with platelet infusions when clinically indicated. Thank you.